So first up, we have Miss Deborah Markham, who works at Warwick, specialises in endocrine surgery, and some of you may have known her in her role at the medical school if you have been here a while like us. So please welcome Miss Markham.
Thanks very much. So one of the things which I think has changed quite a bit since I was a medical student in the sort of late 80s, early 90s, is how much general surgery has become specialised. So at the core of general surgery, there are still a lot of surgical procedures which all general surgeons are able to perform and perform fluently. But obviously in terms of, and those mostly include the emergency procedures. But increasingly, people have been aware that by specialising further, we can improve the quality of the really complex procedures that we need to perform as our elective work as surgeons within general surgery. And so that's happening to a greater and greater extent over time. And in addition to that, there's also some super specialisation of people who are within general surgery but don't do the on-call. So in particular, it tends to be the breast surgeons that don't participate in the on-call because they don't find themselves in the abdomen as part of their elective work, and so therefore they don't feel that it's appropriate to remain doing those general surgical procedures as emergencies. Despite that, though, there's still a huge breadth within general surgery that can attract you as a general surgical trainee, and I hope that we'll be able to explain to you our passions for the different specialist areas that we are involved in ourselves. Sorry, now it's decided to go off. So I'm involved, as David said, in endocrine surgery and also in paediatric surgery. So I do paediatric day case surgery, little bits of paediatric general surgery, but that wasn't what I was going to talk about today. What I was going to talk about today was the general endocrine surgery that I do. I'm getting somewhere near. I seem to have jinxed the whole thing now. And I hope that being able to sort of talk to you about that will give you a little bit of a flavour of what's involved. And then over the course of the evening, I hope that you'll be able to come up to all of us and ask us about anything that you want clarified. So I, of course, am a bit of an old-fashioned girl, so this isn't what you would do if you were starting now. But what I did was I completed my medical school training. I did my house jobs, which in those days were just 1 year, and then I did a 1-year standalone post, which was in A&E and demonstrating anatomy at UCH in London. And then I did a 3-year so-called SHO rotation, and mine was down in Bristol at the French A Hospital, which I chose specifically because I'd really been inspired by one of the surgeons who worked at UCH, where I trained, and he was a plastic surgeon. He was the professor of plastic surgery. He was the Phoenix professor of plastic surgery, and his post was paid for by the disaster at King's Cross, where 30 plus people lost their lives and many more had life-changing injuries as a result, believe it or not, of a discarded cigarette which was thrown down on an escalator which was made of wood and just went up like a torch. And I thought plastics sounded fascinating, and so I decided that I would do this rotation, which involved plastics at the very end, and started off with orthopedics, and then I did 6 months general, 6 months neurosurgery, 6 months general, see how things have changed, 6 months plastics, and I got to do my plastic surgery when I was kind of pretty much almost ready to become a registrar, and I really didn't enjoy it. And what I found was I liked all the fiddly stuff, I liked all the fiddly bits and bobs that are involved in plastic surgery, but what I didn't enjoy very much was that there was no diagnostic dilemma. And that, I think, is the thing which is so fascinating about general surgery and really attracted me to it, is that actually it's a mystery. You know, it's a detective story. It's exciting, trying to find out what's wrong with these patients. So I decided then that I was going to go into general surgery, and I managed to get a research post just doing endocrine surgery research. I spent 2 years looking at parathyroids, and yeah, very exciting. And then at the end of that, I got a registrar job in general surgery, rotated through vascular surgery, colorectal surgery, upper GI surgery, breast surgery, and then managed to do some endocrine surgery as part of that, and just loved it. And then I finished off by doing a year's fellowship at the Toronto Head and Neck Unit, which is the largest head and neck unit in North America, because I wasn't really sure whether I was actually going to be involved in neck dissections or not. And it depends on the size of the unit that you end up working in as to whether you need to do your own neck dissections. In fact, Warwick is quite a small unit, so I don't do my neck dissections, but I didn't know that at the time. And so I'll talk a little bit more about that. So I was asked by David to just talk about why endocrine surgery. And basically, it is just lovely anatomy. I challenge you not to be blown away by the anatomy. It is just beautiful. And every time, I know it sounds really pathetic, but honestly, every time I open the neck, it's a joy. It really is. I mean, obviously watching me is a joy. No, I mean, the neck is a joy. It's just gorgeous. The anatomy is lovely. Mostly, patients are happy with what you do, okay? They are pleased to have had the operation. They are glad with the result, to have the result. And also, it is an enjoyable group in which to work. You work with physicians, you work with endocrinologists, you work with radiologists, you work with the pathologists. You work with speech and language therapists. It's an enjoyable group to work with. The conditions are a nice mix of benign and malignant. I think if you just do nothing but malignancy, it can be quite, debilitating. But on the other hand, the malignancies have their own challenge. The benign disease includes some endocrine, true hardcore endocrine management, and that in and of itself is interesting. I always found it very interesting at medical school, and actually, working with the thyroid and parathyroid in particular, very interesting. And the surgery can be extremely exciting. Sometimes quite disturbingly exciting, but at the same time, quite a lot of the surgery is not that exciting that you spend your whole time as an adrenaline junkie. So, it's got that nice mix. I mean, I put this here because, the thyroid isn't just a rather complicated bit of gristle in the neck. It is actually something that has a function, and I think that is part of what makes it an exciting career. Thyroid malignancies range quite significantly in the way they behave. I always say that cancers are a bit like dogs, some of them are Rottweilers and some of them are teacup chihuahuas. And on the whole, thyroid malignancies tend to be down the teacup chihuahua end of the spectrum, which is nice because most of your patients survive. But, they can be tough, and it's always important to work out which those Rottweilers are before you get too deep into it. So that's just there, just to remind you how lovely the anatomy is. It's not all thyroid surgery. There's endocrine surgery also embraces parathyroid surgery. And also, if you are in a larger unit, you will be operating on patients who have renal failure. And so general surgery also is involved in parathyroid surgery if you get into the more transplant end of the spectrum. So you don't just get into endocrine surgery through becoming a purely endocrine surgeon. You can also do a fair amount of endocrine surgery if you get into transplant, or in some units renal surgery through urology, but mostly it's the transplant surgeons that get involved in the secondary hyperparathyroid patients. And obviously this bit here is the thyroid, and these bits here are the parathyroids, which are enormously expanded by the hyperplasia of secondary hyperparathyroidism. So pros of the specialty, I've already said most of them. But, what's not to like? There are no ghastly things that you have to be in contact with in endocrine surgery. It's lovely, clean surgery. Not like one of the ENT surgeons who I once heard when I was a medical student, and the medical student in the cubicle next to me leapt backwards from this ghastly sort of exudate that was coming down somebody's nose. And the ENT surgeon turned to him and said, "It may be snot to you, boy, but it's bread and butter to me. Which I think was probably a throwaway line that he'd worked on over the years. I think there are cons to endocrine surgery as a specialty. And one of them is that actually there are relatively few endocrine surgeons in each region. So you have to work quite hard to make sure that you get sent to the places where you're going to get to the endocrine training. So you do need to make sure that you're quite focused on it. And you may need to move around within the region to get the experience. The other thing is that the thyroid is an area of the body which is shared with ENT. Very few ENT surgeons do parathyroid surgery, interestingly. I don't quite know why. But thyroids, a lot of ENT surgeons do thyroid surgery. And so increasingly the thyroids are shared with ENT. And that can lead to slight turf wars in some areas. In the West Midlands, actually the majority of thyroids are done by ENT surgeons, not by general surgeons. I'm a funny little outpost of empire of general surgery. And there are one or two other people in the region within transplant, and in Worcester there's an endocrine surgeon as well. And actually the complications are pretty tough. People don't usually die of thyroid surgery, but they do lose their voices sometimes. And that can be very disturbing if you have somebody who's actually had a perfectly normal voice, or indeed has had a singing voice, and they lose that voice as a result of the complications of the surgery you do. Very occasionally, you do have to actually put in a tracheostomy because of bilateral vocal cord problems, usually only in very invasive cancers, but it can be the case. So the complications can be tough. I think I've already probably overstayed my welcome because I've got too many slides, really, just because I love it. But this is a patient who was one of my swan songs when I was at Toronto. So in fact, most neck dissections are not done for thyroid surgery. They're done for squamous cell carcinomas. And so I cut my teeth in terms of my experience of doing neck dissections, of which I managed to do 36 while I was in Toronto for the year, on squamous cell carcinomas mostly. There were a few thyroid surgeons. And this was my swan song. So this young man, 32 years old, suffers from a condition called Fanconi's anemia, which, unknown to him, makes you very prone to developing tumours of the aerodigestive tract. Nobody told him that, and he smoked quite heavily and presented with a tumour of his mucosa in his mouth, which had invaded into his mandible. So this is the before picture. So we put in the tracheostomy at the beginning of the surgery. If you are squeamish, look away now. So this is the middle of the operation. And this is my neck dissection. I just want to show you how beautiful it is. The jugular vein. And this is the missing part of his mandible here. So we removed his mandible. And then, I haven't put all the steps in, but we took a radial forearm flap, a free flap from his forearm, and put it up in his mandible, and we rebuilt him. So yeah, and he did reasonably well after the surgery, had very good function after the surgery. And then this is my biggest thyroid. This lady had multinodular goiter. She suffered from chronic schizophrenia, and she was not keen on the idea of an operation. And this thyroid was gradually getting bigger and bigger and bigger and bigger and causing more and more compression. And although her chronic schizophrenia actually did mean that she did not have capacity to consent or not consent to surgery, the size of that goiter was such that we could not do the operation without her acquiescence, because we could not put her to sleep without having secured her airway. And so eventually one day she came in somewhat breathless and informed me that she was willing to have surgery. So that thyroid weighed 895 grams and took me quite a long time. So that's the before picture, and that's the after picture. I don't have a picture of her just sitting up smiling afterwards, because she went back to her care home and did not darken my doors again. So the other thing that I've been asked to talk about briefly, and I'm sure the others will do, so I won't go into a lot of detail, is actually how to succeed in endocrine surgery is going to be covered, I think, quite a lot by Mr. Williams, who's going to talk about how to succeed in a career in surgery, how to apply for a career in surgery. The most important thing is to pass finals. After that, you need to get good at keeping up your portfolio. The R word is for reflection, obviously, because you will love it so much. We all love it so much, we all do. And then in order to get into core surgery, you need to keep that portfolio well buffed. And then once you're in core surgery, you need to keep that portfolio well buffed, because when you come to ST3 selection, you need to make sure your portfolio is in excellent order in order to succeed. And really, it's not about endocrine surgery. It's about getting on in surgery and then seeing whether endocrine surgery is the right one for you. So the things you can do as a medical student, all the usual stuff. Lots of surgical experience, make sure you try and come to as much surgery as you can. Surgeons are always willing to show off their surgery. They always want to show their own passion to students. We always love showing students what we do. We love getting you scrubbed, we love getting you touching things, and assisting. Students are always assisting me in theatre. Try and make sure you get opportunities to do case reports and posters, and that's mostly about asking. Ask. We've usually got something up our sleeve that we'd like to do. You might consider doing something endocrine in your SSC. Learn your endocrine medicine, it's important. And think about doing your elective in an endocrine unit if you are thinking about endocrine surgery. So plan your elective around it. You might as well get an opportunity to go somewhere exciting. If you can't afford to go abroad, or you've got family ties that keep you in this country, Hammersmith and Oxford aren't too shabby, really. Toronto and Melbourne, obviously, are a bit more exciting. Thank you very much for your patience.